Hello, everyone. Um, just trying to determine if you can all hear us and see us. So somebody that is in the back of the stage and the audience, can you use your reactions button on the bottom of the screen or chat on the far right just to give me a thumbs up or chat, yes, we can hear you and see you. Thumbs up. Okay. So awesome. All right, good. Thank you. Thank you. Thank you. So the couple of you who did that, now that makes us feel way better because I'm not seeing names pop up. So I just want to make sure you guys can all hear us. So welcome to Menopause and Movement. Got Rita White and myself, Cindy Lockhart, here to share some hopefully empowering information for you all. So before we jump in, do use the chat. So put your questions in the chat because we'll come back to that at the end of the presentation to answer your questions. Feel free to use your react button at any time. If you wanted to share some love, if you want to give a thumbs up, react throughout as things start to resonate with you. And with that, I want to turn it over to Rita to introduce herself briefly, and then I'll introduce myself and we will jump in.
Hi, everyone. Thanks so much for joining Cindy and I tonight. It's awesome to be here with you all. My name is Rita. I'm a pelvic floor physical therapist, and I'm the owner and founder of Intrinsic Physical Therapy and Wellness. And we are a PT and OT clinic that's located in Golden Valley, Minnesota. And I've been a PT for probably about 13 years now. And I love all things women's health and just helping people through different stages of life. So excited to speak on this topic tonight.
Excellent. Thank you. So I'm Cindy. I am a registered dietitian, functionally trained. So I call myself more of a functional nutritionist. So I've been doing this for over 33 years. I have a virtual practice. So I'm the founder and owner of Lockhart Wellness Solutions. And my passion is midlife women, especially when I hit menopause and midlife myself. I'm like, holy Toledo, this is real. So it's something that not enough healthcare practitioners are trained in or know. So oftentimes why we get dismissed and unheard, it's not their fault. They're just not trained. And so we really need to dive in to learn about that, which is what we're going to do tonight. All right. So let's dig in. Here's a slide of lots of different symptoms. So please use your reaction button. Give me a thumbs up if any of these resonate with you. Kind of want to see where you are in the phase of perimenopause and menopause. Nobody? Oh, here we go. All right. I was going to say, you got to have at least one. There's well over 100 different symptoms of menopause. We all enter it and exit it differently. Yes. So we have a lot going on, don't we, as women? So we've got to understand why. So before we know what should I do, we have to understand what's happening and why is this happening. So we're going to talk first about what's going on in your midlife body, hormonally and metabolically. And then we'll look at a couple top non-negotiables in regards to nutrition and lifestyle. Because as our hormones and metabolism are changing, we've got to change in regards to what we do. And then Rita's going to take over and talk about menopause and movement. And then we'll end with the Q&A. So let's talk hormones. Now, it's not this simple. I just kind of like this graph because it simplifies the concept behind the different phases in a woman's life. Premenopause, we are dealing with more predictable and cyclical patterns of hormones, whereas in perimenopause, it's rocky. It is like a roller coaster. So, we almost feel like Jekyll and Hyde in this phase because our hormones are doing crazy things and they are significantly and dramatically changing month to month. Menopause is not that you're flatlined. It's just that our hormones start to stabilize. So let's look a little bit deeper. So we've got 3 stages that we go through in midlife. The first is perimenopause. It's also known as the menopausal transition. So it typically starts in our mid-40s, but it can start as early as our 30s. It can last 10 to 15 years. So remember that roller coaster of hormones. You got to hang on to your hats because it can be crazy. But the average length is 4. Again, average length is 4. Some of us feel like we just breeze right through it. Others feel like, oh my gosh, will this ever end? And there are 2 phases. There's early and late. So early perimenopause or menopause transition, we tend to have higher estrogen levels. In fact, up to 3 times what it was pre-menopause. So this is why we start to see our cycles becoming irregular, varying in duration. Some women I hear like, do I ever not have a period? Because it feels like as soon as I'm done, it's starting again the next month or the next week. Sorry, not month. And so we feel like we're more in our cycle than out. We'll notice heavier periods. Maybe we have some clots, breast pain, irritability, rage, anxiety. Later in perimenopause, menopausal transition, estrogen starts to lower in preparation for menopause. So we're going to miss a period, or maybe our periods elongate to 60 days, 90 days. We have them every 2 or 3 months. Common symptoms now would be more like hot flashes, night sweats, depression. Then we hit menopause. Menopause is actually 1 day in time. It's the point in time 12 consecutive months after your last period, known as the second puberty. The average age is 50 to 52, but normal is anywhere between 45 and 55. We have a potential for debilitating symptoms. Remember, we talked about how there's well over 100 identified. And then in postmenopause, which we just in general will use the term menopause versus postmenopause, but these are all of the years after that 1 day in time. And this is really critical in a woman's life because we spend a third of our life in postmenopause, and we're at higher risk for chronic conditions like heart disease, osteoporosis, sarcopenia, which is muscle loss, and cancers. In regards to hormones, we've got all these slew of hormones. We'll talk very briefly about them, but they're all directed by the command center in our brain. The hypothalamus and pituitary direct what our hormones do. So we've got the gonadal sex hormones. We've got the adrenal stress hormones, cortisol. We've got the pancreatic hormone, estrogen or insulin, and we've got our thyroid gland. Now know that these hormones don't typically get disrupted or unbalanced in isolation. If one is off, it tends to pull on that web and take another system or 2 off balance with it. And when we think about this hormone milieu, it really starts with cortisol. So we have to think about the foundations. So cortisol, about 80% of our hormone imbalance is related to cortisol. And in midlife, we're less stress resilient. You can give me a thumbs up if you can resonate with that too, because there can be small stressors that take us over the edge. And your loved ones might be like, what was that? How did you react that way? We just don't respond the same way we did when we were younger. And this can impact insulin and thyroid and sex hormones. Here's all the symptoms that are directly correlated to stress in menopause. So cortisol is a catabolic hormone. It is breaking down our tissues and systems. So we're going to have muscle loss. We're going to have bone loss. We're going to have thinning hair. We're going to have sleep disruptions. We're going to have mood changes, muscle and joint pain. We're going to have that weight gain, which we'll be talking about in just a few moments. What about the thyroid? So we have thyroid receptors on every cell of our body, and the 2 primary functions are regulating metabolism and energy. Super important midlife, right? Because that changes in midlife. Also helps to regulate heart rate, body temperature, and brain function. And the signs and symptoms of low thyroid function mimic that of perimenopause and menopause. So really important for you to get your thyroid tested. Now, the unfortunate part is if you go to your doctor and say, can you test my thyroid? They're going to look at a TSH, which is just your brain telling your thyroid to make thyroid hormones. And there's a very large reference range for that. And so we don't even really know, is it producing T4, which is our predominant hormone, or is it even converting into the 5 to 10 times more metabolically active T3? We don't know if we never test it. And the majority of thyroid dysfunction is autoimmune in nature. So we're not even looking at the thyroid antibodies. I've had many women who have normal TSH, T4, and T3, but then when we finally look at the antibodies, they're super high. And so that's the immune system triggering the thyroid to destroy itself. With our sex hormones, here's the imbalance that happens. So especially in the perimenopausal ages of 35 to 50, we're going to drop estrogen about 35%, but progesterone 75%. So that is the imbalance. You may have heard it termed estrogen dominance, but it's the imbalance in our sex hormones that can affect how we feel and how we function. Why is progesterone so important, and especially that it's dropping so quickly and so dramatically? This is our calming hormone. So we are going to feel more relaxed because it helps to stimulate GABA. It also helps our sleep be more restorative. So when we don't have that progesterone, what do we notice? More anxiety, more irritability, more intense mood swings, memory loss, and sleep disturbances. What about metabolically? This is so unfair, but in perimenopause, after the age of 40, we're going to lose half a pound of lean muscle and we're going to gain a pound of body fat every year. Now, this is doing nothing different, right? This is just natural aging. This is what's going to happen in a midlife woman's body. And that fat mass, maybe you can correlate this with what's going on in your body, is we tend to get it around our midsection, fondly called the menobelly or the menopot. And in fact, we're 5 times higher risk of having our weight shift to the midsection in menopause compared to premenopause. And if it's that deep abdominal fat that surrounds our critical organs, that's called visceral adipose tissue. That's the most inflammatory tissue in our body. And also insulin resistant, which you'll understand soon. Why is that important? We can build our visceral fat over 300% from the age of 25 to 65. Again, if we do nothing different, we just let natural aging do its thing. So we go from that nice hourglass premenopause shape to the shot glass menopause stage in menopause. What else happens metabolically is estrogen has a hunger suppressing effect. So when those levels start to drop late perimenopause into menopause, our metabolism drops up to 300 calories a day worth, which again, if we don't do anything different, that could be 4.5 pound weight gain per year. So that's where we're starting to see some shifts in the body composition and also where it is sitting on our body. Plus, our caloric intake will increase because we don't have the same hunger signals. Or we have more hunger signals at that point. So we might be eating more, but we have lower metabolism. Here's the insulin resistance piece. So insulin's another one of those hormones that we talked about, and we are 2 to 3 times more likely to be resistant to insulin in menopause. So what happens with that drop in estrogen? We reduce our sensitivity to insulin. We increase our fat cell size, especially in the midsection. We're going to talk about that on the next slide. And we're not as metabolically flexible. What does that mean? That means that we stay in sugar burning mode and we just can't get effectively into fat burning mode. So that is going to also make it a little bit more difficult for us. So here's what's happening in your body. So this is your blood stream. On the left is what should be happening. So we've got receptors for insulin on our cells. On the left, when we make glucose or blood sugar, and that's going to happen from the food we eat, but also from stress. Because no matter what stress is going on in your life, whether you know about it or you don't, you are going to prepare for fight or flight, whether you need to or don't. In most cases, we don't. And so that is going to trigger your pancreas to release the insulin, whose job is to drive that glucose into the cells. In this case, on the left, you are insulin sensitive, you are insulin receptive. Things are moving the way they should be. So it's keeping those levels of glucose and insulin lower in your bloodstream. On the right, we become resistant. So those cell doors close and lock, and don't let that glucose in. So then the body thinks you must need more insulin. So we produce more insulin to do a job it already can't do. That starts to build up in the bloodstream. Insulin is a fat storage hormone. Where does it like to store that fat? Right in our midsection, especially in that love handle area. All right. So that might seem like the bad news, but we just have to understand what is happening hormonally and metabolically. That helps us understand, why am I seeing this shift in my body physically, but also symptomatically? So what can we do? So some quick tips of what things you can adjust nutritionally is really hone in on your blood sugar stabilizers. Ideally 3 meals a day that are spaced about 4 or 5 hours apart, where you're having protein, fat, and fiber. So we really need to start with protein, because protein is the most blood sugar stabilizing for us, and it will satisfy us. It'll increase our satiety so we're not so hangry or hungry throughout the day. So clean proteins like grass-fed beef, pastured poultry and eggs, wild caught fish, even your organic plant or organic non-GMO tofu, tempeh, beans, and legumes. Then we want our fiber. And you want about half of your plate coming from these beautiful plant-sourced fiber sources. So really honing in on the majority of that coming from colorful, non-starchy vegetables. You see 3 times. So 3 times more vegetables than fruit, because fruit is nature's candy. Legumes have protein and healthy fiber and carbohydrate. Whole grains are just one ingredient. So that's something like oats or oat bran or amaranth or millet or quinoa. That would be a whole grain. We do need carbohydrates. And then healthy fats, we also need some of those in our meal to help stabilize. Things like extra virgin olive oil, avocado and olives, nuts and seeds. So it's not just what you eat, but when you eat. And so when we think about what we're told conventionally when we talk to our medical provider that I just can't lose this weight, it will not budge off my belly, what are we told to do? Eat less, exercise more. However, that can really cause more stress in the body nutritionally. We talked about that, right? We increase cortisol, we increase insulin, we increase body fat. So we don't want to do that. We want you want to get a nutritionally balanced meals, right? So we need to really focus on 3 meals a day, because it's really hard to get adequate nutrition in less than that. So we need a longer feeding window than what sometimes we're doing, right? We're trying to eat less. So we close that window and we extend our fasting window. Fasting window. So that can be a stressor. So try to extend your feeding window to 12 hours, but we need to move it earlier. So really, to help with the stress resiliency, we should be eating breakfast. We should be breaking that fast within an hour of hour of waking, and then close the kitchen by 6 to 7. Now, why? Because a lot of people are doing what's called intermittent fasting, or they're closing that window of feeding. But what do? Is when we skip. By the end of the day, we're ravenous. So we backload our calories. So we're pushing that window too far the other way. So when you eat earlier in the day, that's when your metabolism is strongest. That's when your insulin receptivity is strongest. Your metabolism is weak. Your insulin receptivity is weak. You're more insulin resistant later in the day. So they've shown studies that if we're backloading our calories as midlife women, we will not lose weight. So we really need to try to shift when we're eating. Make lunch your biggest meal of the day. Make dinner a smaller meal for that reason. So play around with that, experiment, because every body is a little bit different. Sleep. Most important lifestyle habit you will need to master. And really in midlife, we need to sleep as an adult and not a teenager. So it's kind of hard to do that if we've got kids at home still, or we've got into some of these habits that are hard to break. But we want to prioritize 7 to 9 hours of sleep. There is a U-curve risk. So anything less than 7 will be really difficult to metabolically support you. And you might even feel that. Like if you had a short night's sleep, what did you want to eat the whole next day? Did you want to work out or exercise or move? Probably not. So that changes your hunger hormones in just one night. It's a stressor on your body in just one night. So really strive for no less than 7 and really no more than 9, because anything more than that starts to increase inflammation in a woman's body. And we should keep that consistent all 7 days a week, because if we're in bed at 10 all week long, but then we stay up until 1 or 2 on the weekend, that's social jet lag. And that's really hard on the metabolism. We really want that timing to be as close to 10 as possible. And then, up to 8 is fine. So again, that 7 and 9, trying to align with the circadian rhythms, because our deep sleep and your body physically repairs, which we've got a lot of physical symptoms going on in this phase, right? Is you need to prioritize the earlier sleep so that you can get your deep sleep. There's a hypothetical theory thinking that every hour after midnight that you go to bed, you're taking away 2 hours of your deep physical repair time. So we really need to shift our sleep time as well. And if you're shifting your eating time, it should make it a little bit easier to shift your sleep time. Keep your room cool, dark, and free of electronics. That will really help in regards to cortisol and melatonin, which oppose each other. So any kind of light, even though your eyes are closed, it can go through the eyelid and increase cortisol, which is going to lower melatonin and make sleep more challenging. So ideally, we shouldn't be able to see our hand in front of our eyes in bed. So again, to be safe, we might want to use an eye mask or room darkening shades, because especially if you get up in the middle of the night to use the bathroom, you don't want to injure yourself. So please be safe with that. The coolness would be like mid 60s. There are some cooling sheets, some cooling bedding that you can use as well, depending on the night sweats. And then building stress resiliency is a really big non-negotiable in midlife, because we talked about how 80% of hormone imbalance really is related to this stress response, and we're less stress resilient. So we need to intentionally and purposefully and consistently build this practice into our lifestyle. That could be breathing techniques, mindfulness meditation, journaling, prayer, whatever works for you, but we need to build that into our regime, because your mind way stronger than your physical body, and it needs training. But on top of that is really thinking about what we do as women. We wear a lot of hats, we shoulder a lot of responsibilities, we put ourselves last. And this is a time in life where we really need to put ourselves on the front line so that we can care for everybody else. So this is where, if you're a scheduler like me, you like to use a calendar, you like to use a schedule, we can fill it up, right? With our to-do list, our errands, our chores, our tasks, our responsibilities, and then there's nothing left for you. Schedule you time. Make sure that you have white space built into your calendar. Schedule it in. Do something for you, something that you truly enjoy. Delegate and outsource tasks and responsibilities wherever you can. And really find those boundaries. What's nice about menopause is we really build a wisdom and confidence that makes it easier to do that. But sometimes it can be difficult, especially if we're not used to doing that. But really determine who and what do you want to spend your time doing or with every day, night, weekend, month. It is a-okay to say no. And sometimes it's very freeing and confirming to be able to say no to something. And then one more barrier to success. So if you feel like you're doing all of that right, but it's still difficult to manage your symptoms, manage your weight, manage your body composition, we have to think about chemicals. So we are inundated with these toxins in our environment that will disrupt our metabolism and increase our body fat stores and disrupt our hormone balance. And so we have to not close our eyes to that. Now, it's a big one because we're never going to be toxic free, but we are what we eat, drink, inhale, breathe, absorb, and inhale through the air. In our indoor air, where we spend the majority of our time is probably 100 times more toxic than the outdoor air, the water that we drink and bathe in. So we have to really think all the products that we use to clean and to use as personal products come right through our skin into our system. And if we're not great detoxifiers, it's going to be hard for that. For me, I'll give you a personal story. I was doing everything that I knew was right for nutrition and lifestyle. And I still gained what I call the second freshman 15 and had become pre-diabetic, which I've never had metabolic issues. So when I hit menopause, I'm like, what is going on? And it wasn't until I did a toxin test that I found I was full of mold. And 25% of the population will be debilitated from that, but 75% can still have mold and not even have a symptom. So I was one of those because I didn't have significant symptoms other than the weight gain and the difficulty with prediabetes. So it wasn't until I went on mold detox plan that I lost all the weight and I'm out of prediabetes. So we can't close our eyes to the potentials of what the environment also contributes to this whole story. So if that kind of intrigued you and made you start thinking, gosh, I want to know more, I need to dive deeper into this, I created a 12-week program for that very reason, because I feel it's so important for women to truly understand what's happening in their body. What are all of these contributing factors and what do we have access to do? There are so many things that we can do ourselves within our nutrition, our lifestyle, and our environment to help ourselves. And so this is a 12-week program that includes a very comprehensive functional lab testing panel, actually $300 worth, includes that full thyroid panel we were talking about, personalized one-on-one support. So you'll fill out a couple of intake forms. We'll meet one-on-one after your labs come back to personalize a plan for you. And then again, at the end of the program to see what's the best next steps. There's 12 expert-led weekly modules. You can listen to these on your own time. They're typically 30 minutes or less. And then a bi-monthly group session, because it takes community. It takes support. We want to be heard. We want to be listened to. We want to support others and we want to be supported. Community forum. You can chat with your cohort of women 24/7. You'll get weekly resources and email support to follow up every educational module that you receive. And the next program will begin on Sunday, April 12th. So I only take 10 women at a time because I want this to be inclusive and special and intimate. And so that is coming up. I already have a few women registered. So if this is something that you're interested in, you can certainly reach out. But maybe you have some other conditions or issues in layers, I call them, that need to be addressed as well as the perimenopause and menopause. So there's also one-on-one personalized care. So it's very individualized based off of what you need. Maybe you don't know what you need. We can do a free discovery call. So you can just email me at cindy@lockhart-wellness.com. Happy to book a free discovery call just to listen to what you're dealing with, what your concerns are, challenges, what your goals are, to determine what the best next steps are. Otherwise, you can go to my website, lockhart-wellness.com/menopause, read up more about the different menopause programs. And I also have a menopause membership that you do not need to do the program first to become a member. And with that, it is Rita's turn. So I'm going to turn it over to Rita and then we'll open it up for Q&A.
All right. That was some wonderful information. There's so many facets, I think, to what we are dealing with when we are in these hormonal transitions. And like Cindy touched on, women are busy, we have a lot on our plates, and the interactions with just everything that we're doing, from stress to what we're eating to sleeping to our movement, really does play a role here. So we're going to talk a little bit more about movement and pelvic health. So we'll jump into that. So we know that movement is essential for women in this stage of life. heart disease is the number one killer of women right now. And so being able to do aerobic exercise for our cardiovascular health is super important. Movement can also help manage weight alongside all the other things that Cindy talked about. Movement can be a great form of stress reduction. It can help us sleep better, and it can improve our brain health and reduce brain fog in some cases. So we want movement. That's a big goal for us to utilize that tool as we age. And I think sometimes we overlook the importance of it, or there's some things that stop us from using movement as well as we could. So we'll talk more about that. So the barriers to movement, a big barrier is pain. Often as we age, we do feel a little bit more of the aches and pains in our joints and in our muscles. There's some research that showed that 70 to 80% of perimenopausal women experience pain. That's a lot. So pain is a huge barrier. And I think we don't always know what to do when we experience pain, right? Like we wonder, is this harmful? Is it okay to keep moving if I feel pain? Is it not okay? Do I need to rest? Can I push through? That's a big thing that we work with patients in physical therapy on, is kind of understanding their pain. The tricky part that this research study found was that a lot of the pain was really not reflected in imaging. So you might experience pain, go get an x-ray and MRI, and it doesn't really match up with the pain that you're experiencing. And we see that over and over. So you can have pain. Pain can absolutely be real, but it might not show up on imaging, and that can just make it a little trickier for us to understand what it is we're dealing with. But working with providers that really know pain and the musculoskeletal system can help you kind of tease that out. So pain is a big barrier. And then the other piece is that pelvic health conditions are another big barrier. So for 1 in 2 women, urinary incontinence can negatively affect exercise participation. So to me as a pelvic floor therapist, I'm like, we've got work to do. And that's why I love doing what I do, because their pelvic floor function, our pelvic health is so important. But then we can just see how, if we're dealing with symptoms like incontinence, just that snowball effect it can have on our health. So we know too that urinary incontinence is one of the leading reasons that people end up going into a nursing home. So there's so many reasons that we want to really get ahead of any of our pelvic floor symptoms, and it's never too late to work on them. So this one study found that half of women with urinary incontinence report stopping or modifying their exercise due to symptoms. So we really just want you to be able to do the movement that you love and enjoy doing, and that's good and healthy for your body, with not having to deal with those pesky pelvic floor symptoms. So there's something called musculoskeletal syndrome of menopause, and this is due to that declining estrogen level that Cindy was talking about that happens in menopause and that postmenopausal period. So because of the declining estrogen, we can have that widespread joint pain, muscle loss, which is sarcopenia, and rapid bone density reduction. Over 70% of women are affected, which can cause stiffness, decreased mobility, and increased fracture risk. So all of that, can be a big barrier to moving. So common conditions that we see in musculoskeletal syndrome of menopause would be arthritis and tendinopathies. So arthritis, that happens when there's a breakdown of the joints, where we see that nice cartilage that allows for smooth motion between our joints to kind of break down and the joint space to become smaller. And so often that can create kind of that achy, stiff kind of feeling. We mostly see it in hips and knees in women, but it can also be really at any joint, shoulders, ankles, fingers, those can all be affected as well. And then tendinopathies, so that refers to inflammation or irritation at our tendons. And so tendons, remember, are where muscles attach to bone. And so often you'll feel these tendinopathies where it feels like, oh, there's kind of these like really tender spots or hot spots kind of right by a bone, but it's not quite in the joint. And so common tendinopathies that we'll see in women during menopause would be like a rotator cuff tendinopathy. So somewhere in the shoulder, a lot of times you'll have pain with like moving your arm out to the side or sleeping on your shoulder at night. A gluteal tendinopathy, so that can be in that outer hip. Again, you might have pain at night when you're laying on your side or with doing things like a squat. A lot of people will get an adhesive capsulitis, so like a frozen shoulder, or plantar fasciitis. And both of those have to do with some of the fascia that becomes restricted due to that lack of collagen and flexibility in the tissues that happens because of that decreased estrogen. Then another common condition would be pelvic floor dysfunction. And so that reduced estrogen will affect the pelvic floor muscles and those tissues. We lose 2% of our external urethral sphincter each year after age 35, which can lead to increased incontinence. So that external urethral sphincter is like that sphincter muscle that squeezes. We have voluntary control over it, that we can squeeze to make it so that we're not just emptying our bladder, and then it relaxes when we do want to empty our bladder. And so just because of aging and because of the decrease in that estrogen, we just lose function of it. So we need to do things to support everything around that structure so that our bladder is not just emptying when we don't want it to empty. We also know that pelvic organ prolapse is more common with declining estrogen levels. When we have less estrogen, we have more of the thinner, weaker, and less elastic collagen tissue, and that can make it so that those pelvic floor muscles just lose some of their like flexibility and mobility, and then all of our pelvic organs are suspended by ligaments, and those ligaments also lose some of their elasticity. And so everything, gravity just kind of takes a toll and starts to kind of come down. And that pelvic organ prolapse can happen when those pelvic organs, either the bladder, the uterus, or the rectum, kind of bulge down into the vaginal wall and can create like a bulge, often a heaviness. It can feel really uncomfortable to some people. And so again, that lack of estrogen can contribute to the pelvic organ prolapse. So we know with estrogen that the role of it is multifactorial, but it is anti-inflammatory. So Cindy mentioned, a lot of how inflammation is something that we want to work to decrease in various ways. And so we're losing that estrogen, which is an anti-inflammatory kind of naturally in our body. Estrogen is anabolic, so it helps us to grow our muscles. So that's why we see that we lose some of the muscle growth as we go through menopause. Estrogen can also affect the actin-myelin coupling, which is just kind of the fancy biophysiology for the way that our body produces power, speed, and coordination. So we can see like a decrease in our balance or just kind of our ability to like get up and go quickly. And then estrogen promotes bone density. So this is where we can see osteopenia or osteoporosis happen with that loss of bone density. All right, so treatment for musculoskeletal syndrome of menopause. So we know that hormone therapy can be effective. That's always a choice that you can talk to with your doctor to see if that might be appropriate for you. Lots of good studies coming out now that it's probably more helpful than harmful in a lot of cases compared to what we used to think. So definitely worth a discussion. Strength training is a big one. We see that resistance training can really help with that muscle atrophy so that we are not losing muscle, but we're maintaining it. And then that can have a lot of downstream effects. And then lifestyle adjustments like Cindy touched on, movement, nutrition, sleep, stress reduction. So we're starting to see a pattern here on all the things that help us through menopause. So with tendon pain specifically, sometimes hormone replacement therapy can help to decrease the irritability of those tendons. Exercise can really help. So we can do like tendon specific exercises, which are often loading the tendon in specific ways, usually with like an eccentric protocol. You could work with a physical therapist on that, or even just low impact exercise that doesn't exacerbate the irritation of the tendons can be really beneficial. And then just knowing how to work around that tendon pain by avoiding compression on the tendon and then working on load management strategies. So how can we move in ways that doesn't stress that tendon more and create more irritation? And then with arthritis, we know that strength training can be really helpful. So arthritis affects the joint. And so the more that we can strengthen the muscles around the joint, the more we're able to provide stability to the joint. And just for long-term health, like arthritis can be a normal part of aging to some extent. Doesn't necessarily mean that we have to experience pain with arthritis. Those can be two different things. And so sometimes if we can increase our mobility and the flexibility of our muscles, but then gain strength in our muscles, that can really make a difference for how much stress that joint is under and can help to really reduce the pain. We know that stress reduction has been shown to help with arthritis too. We think a lot of that has to do with the inflammatory nature. So any times that we can decrease inflammation in the system, typically the joints respond really well and the pain can be lessened. And that's similar to with the nutrition advice, things like that Cindy already kind of touched on, but primarily a plant-based Mediterranean style diet has been shown in the research to be helpful for people that deal with pain from arthritis. All right, and then when we talk about pelvic floor dysfunction, so pelvic floor dysfunction can cover a wide variety of symptoms, and so we most often think about incontinence. That could be urinary or fecal. We could have pelvic organ prolapse. Sometimes it's just an overall feeling of weakness and heaviness in the pelvic floor. Can be pain. We can have tightness in the pelvic floor too. That can be pretty painful. We want to really improve our strength and coordination of our pelvic floor muscles. So that coordination piece can be key. A lot of times some of the generalized advice of just do your Kegels really promotes strengthening, but we want to make sure that we know how to turn on those pelvic floor muscles and turn them off. So sometimes people aren't dealing with just weak pelvic floor muscles, but they're dealing with pelvic floor muscles that are tight. Really common for us to store a lot of tension in our pelvic floor muscles. So it's kind of similar to like jaw pain or that upper trap pain where some of us hold tension in these areas, and it can be really common to hold that tension in our pelvic floor muscles. We want to have a little bit of activation in those pelvic floor muscles because that helps us to not just empty our bowel and bladder when we don't want to, but we don't want them to be overly tight. And so sometimes we've gone through life not even realizing that they are tight. And if we just start strengthening them, there's really one, it can make it more tight, but then we also feel like we're not gaining a lot of strength because a tight muscle is really hard to strengthen. So we want to make sure we're able to relax. And that can help with fully emptying our bladder, fully emptying our bowel, can help with constipation, it can help with pain. And then we can better have those pelvic floor muscles activate when we need them to activate. So if our bladder's filling up and we feel a sneeze coming on, we want those pelvic floor muscles to really be able to fire so that they can counteract that pressure of the sneeze so that we don't experience any leaking. So the best way to figure out what's going on with your pelvic floor muscles is to have an internal exam done by a physical therapist because we're really able to assess that, and then we can direct treatment. So we just don't want you to be doing the wrong thing for your muscles. But the cool thing too is that what we see in the research for pelvic floor dysfunction is that working on the pelvic floor coordination plus overall resistance training and strength training is really what moves the needle, especially with things like incontinence and prolapse. The pelvic floor muscles, really, we kind of want them to act automatically, and we don't want to have to think about them all the time. But sometimes we've gotten into patterns where they just aren't activating as we want them to. That's kind of that coordination piece. So like if you kind of trip on something, you'd want those pelvic floor muscles to turn on. If you're going to cough really hard, you'd want them to turn on. But sometimes over time, we actually have like the opposite happen where they don't turn on, or they even kind of bulge. So a lot of the retraining that we do is how do we coordinate those pelvic floor muscles while we're doing these bigger muscle movements. And so it can really help to do globalized strength training for the upper body and lower body while we're focused on our breathing and our pelvic floor. So then there's something else called genitourinary syndrome of menopause. So remember, syndromes are kind of just a collection of symptoms that we've given a name to. So it doesn't have to feel like a million different diagnoses, but these are just really common symptom patterns, right, of those like 100 symptoms that Cindy was talking about that we can kind of categorize. So the genitourinary syndromes that we see with menopause include an overactive bladder, incontinence, vulvovaginal dryness or irritation, and then that pelvic floor muscle dysfunction. So we know that it is chronic and progressive just because of the decrease in hormones. It doesn't necessarily get better by itself. So as we age, we kind of keep seeing these symptoms continue. And so this is something that just requires that daily maintenance. We want to be aware of it, and we want to know that just because it might not get better by itself doesn't mean there's nothing we can do for it. So there is a lot we can do. Sometimes we talk about these symptoms as if they're kind of just a normal part of aging, and while they might be very common, we still don't have to just live with them and accept it without really doing anything about it. So lots that we can do to help treat these symptoms. We do know that the vasomotor symptoms, like hot flashes, can get better with time, usually as you kind of go through that transition of menopause, but these other symptoms of the genitourinary syndrome often don't. So 5 things that can treat the genitourinary syndrome of menopause besides hormone replacement therapy. So hormone replacement therapy is an option. You can talk to your doctors about that. But other things that are non-hormonal would be a vaginal moisturizer. So really finding a good one that works for you can do wonders. So it doesn't have to be like a hormonal estrogen, like vaginal estrogen, but we can use just these vaginal moisturizers, and that can really help out with like the dryness, the irritation, the itching, those kinds of things that you might feel. Vitamin D has been shown to help, so you can talk with your doctor or dietitian about kind of the proper dosing for you with that one. Utilizing a vibrator has actually been shown to be really helpful for pain, for dryness, for irritation. So that's just something to consider because it's an easy tool that we can have access to. Strength training, once again, that shows up. And then pelvic floor therapy, and we know that the combo of those two can be really helpful. So strength training, we just kind of see that one as the non-negotiable, and there's just more and more research that shows that we got to be doing resistance training. So strength training wins across the board throughout all the research studies that we see. It's the closest thing to a magic bullet that we have to reduce symptoms in perimenopause. But we, need that within that holistic lifestyle of good nutrition, sleep, and stress management. But strength training can improve insulin sensitivity, it can improve mood, so it can be really helpful for mental health, it can reduce weight gain, decrease hot flushes. There's one study that showed that resistance training can reduce the intensity and frequency of a hot flash by 44%, which is pretty incredible. And it can also improve bone density. So for strength training, we want to be trying to do that 2 to 4 times a week. Ideally, we want 2 to 4 sets of our exercises. And probably the most common thing that we see with strength training, especially in women, is that we're underdosing it, meaning we're just not taking our exercises to failure so that we're not allowing our muscles to really break down to then be able to regrow and atrophy and strengthen. So we can gain muscle mass throughout menopause. It's just harder. So it's really important that, if we're going to bother showing up and moving, that we may as well make the most of it and kind of exercise in the way that we know will help us the best. And so usually the guidelines for strength training are to do 6 to 30 repetitions of an exercise to failure. So what that means is when you are, doing your reps, your first couple reps should be pretty easy. By your last one, you want to feel like it is significantly harder than your first one and that you can't do another one. And so you don't have to lift super heavy for only a few reps. You don't have to, lift lighter for more reps. You can do whatever you prefer. So some people are like, I just want to do 5 reps of really heavy weights. And other people are like, I'd prefer to lift a little bit lighter, but just do a lot more reps. Either one can be just as effective for muscle strength gain. But we just want to make sure that you're actually utilizing the right weight to get you to that failure point, if that kind of makes sense. So whether you do 6 reps lifting 100 pounds or you do like 20 reps lifting 30 pounds, right? We want to kind of be able to figure out where that failure is, and we just want to try to hit on all the major muscle groups when we do that. So that's strength training. 2 to 4 times a week is usually plenty. We want to have some recovery time in there so that we're not overstressing the body and we're allowing for that tissue repair and that muscle atrophy to take place. We also want to incorporate some aerobic training. So the general guidelines would be 150 minutes a week. So that's about a half an hour, 5 days a week. Brisk walking, cycling, rowing, dancing, those can all be nice, rather like low impact options. If you tolerate higher impact options, that's totally fine. It just kind of can depend on how your joints are feeling, how those tendons feel for you. We want to make sure we can incorporate a little bit of balance training. We can work on our balance. So a lot of times as we age, we feel like our balance just gets worse, but it's a skill that can be practiced. And so it can be so helpful because we really want to reduce our risk of falling. So work on your balance, and then having those mindfulness practices like yoga, Pilates, stretching, breath work, all of that can help really just with like that holistic stress reduction movement. It can just be healthy for your whole body. All right, so we just want to think holistically. We want to think about what we're eating, how we're sleeping, how we're moving, and how we're managing our stress. So it kind of keeps coming back to that, the same theme that you've heard us talk about throughout, but that's really the key. So if you are looking for more support, like I said when I introduced myself, I have a private pelvic floor physical therapy practice in Golden Valley. We'd love to help you out. So we have physical therapists and occupational therapists that really specialize in women's health kind of throughout the lifespan. And we can work with you on your pelvic floor muscles, really identifying what's going on there, and then helping you build an exercise routine that works for you, and to make sure we're working on really addressing any pain that comes up so that the pain and those pelvic floor symptoms are not barriers to your movement. All right, and yeah, we kind of talked through what we can do. If you have any questions, just feel free to reach out to me. I think on the next slide, yep, we have the therapists at my clinic, Intrinsic PT, that specialize in pelvic floor. So feel free to contact us via phone or email if you have any questions.
Wonderful. Thank you, Rita. That was so awesome. Learned so much there. I want to open it up for any questions. So if you would like to open up your chat and ask any questions that way, that's going to be the best way for us to um, do this. So it looks like Karen, how do we handle food timing during insomnia nights, early morning? That's a great question. And, we have to be realistic, right? Depending on what our work schedule is, what our life schedule is, you do the best that you can. But I think as much as you can still replicate what we talked about, like keeping your eating window earlier. So eat within an hour of waking and then try to really shut down the kitchen earlier. So insomnia, that's a vicious cycle, right? We're just going to have so many confounding factors that are making it harder to fall asleep and stay asleep. So that's got a lot of layers to it. So we just have to kind of dig in to figure out what are the things that are really preventing you from getting that. But I think in regards to the food timing, you can still work with whatever your routine and schedule is. Thank you, Cindy. So very informative. Julian, lots of information. If you could both pick one thing, well, that's a loaded question, Julian. One thing that is most important for most people, what would you pick? I understand it won't be for everyone. Yeah, everyone is so different. I would say as a functional nutritionist, you would think I'm going to talk about nutrition. I really say it starts with sleep. So for me, I would say it's going to be either your mastering of your sleep routine, and then the hopefully sleep quality will follow, or the stress resiliency piece. Those would probably be the first two because those really are foundations that will dictate what happens nutritionally for us. So that would be my answer. And I apologize, I gave you two instead of one. Rita, what about you?
You can probably guess, as I talked about a lot, I would say strength training. I think we just see that we underdose it so much, and that all the research coming out now is showing all the amazing effects that resistance training can have. So we gotta strength train to failure. We gotta build muscle. It really supports us long term as we age.
Yeah. And I think it's just a lot of times it's misconceptions and misguidance. But again, a lot of our practitioners just aren't trained in this area. But what do we do when we're trying to lose this resistant weight or manage our symptoms is we tend to do more of the high intensity, long duration cardio, which can be more stress on the body. So yes, what Rita was mentioning is just reprioritizing. Kat, thanks so much for doing this. Great to hear knowledgeable people talk about issues but are often dismissed. And it's that's why we're here, because we do know that there's not enough training out there yet. Now women are starting to speak up. I do foresee that will change over time, but we're just not there yet. So we just have to find the people that are trained and that do understand to help, to guide and listen and know how to work with you one-on-one. Any other questions? So excited that you ladies joined us tonight. As I mentioned, we will have this edited and then we will be sharing the link with you. If you have any questions beyond today, do not hesitate to reach out to Rita or myself. We'd be happy to navigate any further questions or concerns that you have, and hope that you have a wonderful night and a smooth perimenopause and menopause time. Thank you so much, everyone.
Thank you
Bye bye.
all.